Good morning. Good morning, guys. I'm going to present on topic today: sudden cardiac arrest in athlete. So I will start the with definition first. Definition of athlete. So the key point here is athlete is a part who those participate in an organized team or individual sport that requires a regular competition against each other, and they places a high premium on excellence and achievement, and they require some form of systematic and usual intense training. So that's what meant by athlete lah, than a normal person. So sudden cardiac death in athlete is that occurs about driving exertion or shortly less than 1 hour after the exertion. So if you see the definition of sudden cardiac death, so it will happen unexpected death 1 hour from the onset of the symptoms lah. So that is meant by sudden cardiac death. So in athletes is during exertion or shortly less than 1 hour of the exertion lah. So the epidemiology wise, okay, the risk group usually males, black people, African Americans, and the game usually that they play and they have involved is basketball lah. So the etiology wise, there's two here, inherited and acquired. So the structurally normal and the structurally abnormal for the inherited. So if structurally normal one involves the malfunction in the ion channel lah. So these are the causes lah: Brugada, long QT syndrome, and idiopathic VF. So for the structurally abnormal, we call it as a cardiomyopathies involving the heart itself. So HOCM and the right ventricular cardiomyopathy or dysplasia. So other causes are like coronary artery abnormalities and valvular heart disease lah, with aorta parties. So acquired one, if it's actually normal, we can the causes are on commercial causes, substance misuse, or in environmental factor lah, hyper or hypothermia. And sexually abnormal is ischemic heart disease or myocarditis lah. So this is how I differentiate with the inherited and the acquired. So there's another etiology, the causes that this one, age related. If age related more than 35, atherosclerotic artery heart disease. If less than 35, usually genetic or other acquired cardiovascular heart disease lah. So the important thing here is that usually if 30% of sudden cardiac death, they have autopsy negative, toxicology negative, but the diagnosis usually will be made after screening of the family members lah. So they ask further history taking. So then exercise is the trigger of all this sudden cardiac death lah, especially in the genetic or cardiac abnormalities. So few things that I'm gonna mention. So how you're gonna screen the person first. So first we go with the history, physical examination, and also the investigation. So from the history wise, you ask all about the failure symptoms, heart failure symptoms, SOB, syncope, dizziness, PND or topnia, swelling of leg, peroneal edema, and then you proceed with the physical examination. Okay, you see for murmurs or auscultate for murmurs, and also for the investigation wise, you go for the echo ECG. So from ECG wise, there's the international recommendations for ECG interpretation in athletes. So how you classify ECG in athletes lah? So what is normal for them, what is abnormal for them, and what is borderline ECG, and do they need to be investigated further or not? So this is based on the normal ECG findings in athletes, usually increased QRS voltage for LVH and RVH, and incomplete RBB, and early reposition and ST segment elevation, and also ST elevation followed by T wave inversion to V1 to V4 in black athletes, and T wave inversion V1 to V3, the age less than 16 years old. Sinus bradycardia less than 30 beats, and ectopic atrial or junctional rhythm, the Morbitz type 1 secondary AV block. That is for the normal one. Okay, then the borderline ECG is the left axis deviation, left atrial enlargement, right axis deviation with right atrial enlargement with complete RBBV. So the abnormal ECGs here is T wave inversion in any leads, ST segment depression, pathologic Q wave, and complete LBBB, and QRS more than 140 millisecond duration. Epsilon wave usually we've seen in ARVD lah. So ventricular pre-excitation, prolonged QT interval more than 460 millisecond. Brugada type 1 and profound sinus bradycardia less than 30 lah, and PR interval more than 400 millisecond with morbid type 2 and 3 degree AV block with more than 2 PVC, which is the premature ventricular complex, atrial tachycardia and ventricular tachyarrhythmia. Okay, this is all the abnormal one. Okay, so if let's say it's a normal ECG, there's no further evaluation needed lah. So if let's say it's abnormal, so then we investigate like what I mentioned just now lah. So I will proceed with most common cause of sudden cardiac death is HOCM lah. So what is that actually? It's a disease that caused by autosomal dominant genetic disorder, so involving the thickening of the heart. So what part of the heart is usually mainly the septum lah. So it called as a septal atrophy, asymmetrical septal atrophy. So what is the mutation? What is the genetic result? Is because of the mutation in the cardiac sarcomere protein genes. So they mention as beta myosin gene. So that is the one lah. So yep, the classification wise there's two, obstructive and non-obstructive. So if you see the obstructive wise, it will cause the septal hypertrophy, and it will obstruct the outflow tract lah. So if you see the non-obstructive obstructive, so there is a hypertrophy of the left ventricle, which will cause the reduced end diastolic volume and will cause the reduced stroke volume, hence the reduced cardiac output lah. So the other one is apical hypertrophy and another one is fibrosis lah. So epidemiology wise, age is one of the causes SCD in young. Clinical features like what I mentioned, all the signs and symptoms, SOB, syncope, pre-syncope, chest pain, autopnea, dizziness, sudden death. Physical examination wise, prominent A wave lah. So this one is from the JVP waveform. So JVP waveform, there's A, C, X, Y. So this one, if HOCM, the prominent was A wave lah. So which is the forceful atrial contraction, because of the increased resistance over the ventricular filling lah. So that's why it's a prominent lah. S4 heart sound and displays apex beat. So this from the physical examination. From the ECG wise, we can find LVH, LAD, and T inversion from V2 to V4, and Q wave in lead 1, AVL, and V4 to V6. Delta wave and P mitrale. Delta wave is like actually like this. So this is delta wave. If P mitrale, usually it's in a P lead 2 actually. So P mitrale, it's a broad notch bifid. So this is P mitrale now. Echo wise, from echo wise, the septal wall thickness is more than 15 millimeter lah. Asymmetrical septal hypertrophy. And from the cardiac MRI, this the main gold standard actually they said lah. So to look for the myocardial fibrosis. Differential diagnosis that I can give is aortic stenosis and restrictive cardiomyopathy. So from management wise, for the pharmaco I give beta blocker, and I avoid ACE inhibitors and nitrates like because the worsening of LV outflow tract obstruction. Surgical wise, I will go for septal myomectomy. So what you want to advise for this kind of patient who diagnosed as HOCM? So you ask them to avoid competitive participation in high dynamic or static sports, avoid the heavy lifting, and can go for low to moderate intensity exercises lah. And they can actually able to participate in low dynamic or static sports like bowling or golf. So this is like a small differences between the HOCM and athlete's heart lah. So based on the LV wall thickness, for the HOCM is more than 15 millimeter. For the athlete's heart, it's basically less than 13 millimeter lah. So the grey zone is 13 to 15 millimeter lah. So the differences is like LV cavity is less than 45 millimeter and is a unusual pattern of LVH lah. And it has a LA enlargement with abnormal LV diastolic filling. So most of them will have family history of HOCM, and in sex-wise the female is more common lah. So the athlete's heart usually LV cavity will be more than 55, diastolic filling will be normal, and the LA size will be normal lah. This one more common in male, and there's no family history of HOCM lah. Okay, and the thickness decreases with deconditioning. So that's the difference between HOCM and this heart. That's all.